Asthma and Olympic athletes. What do Australian sports doctors know? You are listening to ReachMD XM157, the channel for medical professionals. Welcome to a special segment, Focus on Sports Medicine. I am your host, Dr. Mary Leuchars. Joining me is Professor Ken Fitch, who is a member of the Australian Olympic Committee Medical Commission, Chair of the International Olympic Medical Commission Games Group, and Chair of the IOC Independent Asthma Panel. He is a professor at the University of Western Australia in the School of Sports Science, Exercise and Health, located in Perth, Australia. Ken has been involved in no less than 15 Olympic Games and has played a leading role in sports medicine in Australia for over 40 years. Today we are discussing asthma in the Olympic athlete and what Australian sports doctors know about this condition. Dr. Fitch.
Hello, Mary. I'm fine and lovely to talk to an Australian voice in North America.
I can say the same thing. What I want to know firstly is what research have you and your Australian colleagues been doing into asthma and the elite athlete?
Well, this has been a subject of great interest for me for over 40 years and the subject of my doctoral thesis in medicine many years ago. And that was more in the early stages of what caused athletes to get asthma. And then, of course, we moved on from there to how to prevent it. Following a meeting in Palm Springs in 1984, I started to research the effects of drugs to treat asthma and did they affect performance. And, of course, one of the first ones we started with was something that the older doctors in your country would remember, theophylline. But from there, of course, we moved on to some of the other newer drugs, including, of course, the beta-2 agonists. But what we've been looking at in recent years has been, are elite athletes more prone to asthma than their lesser elite counterparts? This probably began to surface around about 17 years ago when the Skiing Federation found that athletes who finished in the top half of cross-country skiing had far more asthma than those that finished in the bottom half of any competition. In the first instance, it was believed that this was because athletes were obtaining some benefit from taking beta agonists, because it was on the prevalence of use of beta agonists that these numbers were established. The athletes were not challenged and shown to have asthma or airway hyperresponsiveness. From there, it's moved on, and what we now know is that, in particular, the cross-country athlete is probably damaging his or her lungs by breathing huge volumes of very cold, dry air, which is causing airway mottling and release of a number of chemicals which can cause also bronchoconstriction in the airways. We also know that the cycling people have now taken over from swimming as having the highest incidence of asthma in Olympic athletes, that is the summer athletes. And we know that many cyclists also have huge lungs, breathe for hours on end air which is often polluted by products of combustion because of cars, etc. And finally, of course, swimming, which is for many years has been used as treatment for asthma. We're now starting to find that athletes are actually acquiring asthma from many, many hours spent in indoor pools. And we believe that this is due to chloramines that are in the atmosphere that they're breathing.
So the cure has resulted in disease, in this case, for some athletes.
Well, I think we need to put this into perspective because as part of my MD thesis, I actually had 46 children swim from Perth to Sydney or equivalent distance, and we monitored their asthma for 5 months, and their improvements were unbelievably good. And at that time, we established the asthma swimming classes in Perth, which have gone on now until about 2 years ago when they were terminated for the simple reason that all swimming coaches knew how to manage asthmatics anyway. And of course, the management of asthma had improved with inhaled steroids to a greater degree, and perhaps they didn't need such specialised swim coaching. But asthmatics in this country are still put to swimming. No, we're not talking about them. We're talking about the people that are swimming 4 and 5 hours a day in indoor heated pools. They're the ones that we fear for, and we haven't got an answer at the moment. And of course, the other thing I didn't mention is that it is the endurance athlete rather than the sprint athlete who tends to acquire this. And if you want an example of this, nothing's better than those of you who know about the Winter Games, is that the more than 5-fold difference in the incidence of asthma between competitors in ski jumping and the Nordic combined. Now, the Nordic combined event, of course, are ski jumpers who also have to cross-country ski for 15 kilometres. So they need a high degree of endurance to be able to compete successfully in this winter event. And that's a remarkable difference, a 5-fold difference. Ski jumping is one of the lowest of the winter events in terms of the prevalence of asthma. Nordic combined is up there with cross-country skiing and biathlon in the top 3.
Wow, that is interesting data. And if you're just joining us, you're listening to a special segment, Focus on Sports Medicine, on ReachMD XM157, the channel for medical professionals. I am your host, Dr. Mary Leuchars, and I'm speaking with Dr. Ken Fitch, and we're discussing asthma and the Olympic athlete from an Australian perspective. So, Dr. Fitch, just getting back to beta agonists, how are they currently restricted in elite sport?
It's had a checkered career going back to Munich 1972 when I was denied use of them by the International Olympic Committee's Medical Commission. But the concern with beta agonists have been twofold. Firstly, they are a sympathomimetic and, of course, in very large doses can cause some increases in heart rate and etc. But more importantly, there are other issues. There have been for a long time concerns about misuse of them, and this, of course, started with phenoterol back in New Zealand about 20 to 30 years ago, with sudden death occurring from phenoterol, which was used in pretty high dosage. In more recent times, and particularly in North America, there are great concerns with salmeterol, a long-acting beta agonist, and the FDA has actually terminated some studies over there because of side effects. So that's one issue there. There are some major health issues. The second issue is that oral beta-2 agonists do improve strength, and so there is a need to distinguish between oral versus inhaled. And I was involved with about a decade ago in combination with the Barcelona laboratory where we gave subjects in Perth oral and inhaled salbutamol, and we've a test now that we can largely distinguish this based on the level of salbutamol in the urine together with the ratio between their S and their R enantiomers.
So what proportion of Olympic athletes would be using a beta agonist to control asthma symptoms at the coming Olympics?
Well, we know that very well now, and for this reason, that from Atlanta in 1996 to Sydney in 2000, there was a very marked increase in the incidence of athletes using beta agonists. It went from 3.7 to 5.7% in just one Olympic Games. And in between that, we'd seen a similar percentage up to about 5.8 in Nagano at the Winter Games there. So the IOC then had a symposium in 2001, and we decided to introduce the fact that athletes to take beta agonists had to demonstrate they had either asthma or airway hyperresponsiveness. And so they either had a bronchodilator test or they had to have one of several bronchial provocation challenges, which could include exercise such as running or cross-country skiing in the field, in the lab, on a treadmill or on a bike. It included hypertonic saline as a wet challenge, and it also included eukaptic voluntary hypopnea or the EVH test, and it also included methylcholine challenge. For Beijing, we've introduced a new challenge with dry powdered mannitol.
And will you be using that just on the Australian athletes in Beijing, or will all athletes have access to that test?
Dry powdered mannitol has been developed mainly in Sydney by Dr. Sandra Anderson, who's well known in North America as one of the world's premier respiratory physiologists. And it is approved for use in Australia. It's a very simple test, easy to perform, and it has been approved for use throughout Europe, as well as in my country and Korea. Unfortunately, at this stage, it has not been approved by the FDA for use in North America, but hopefully it will soon, because it's an excellent challenge, very safe and very simple to institute and very accurate.
I wondered what we've learned from previous Olympics that Australian sports doctors are going to use in treating their athletes' asthma in Beijing.
We're very prepared for this. We have amongst our team a sports physician with particular expertise in this area, and Dr. Holzer has worked with Dr. Anderson in developing the mannitol test and having it validated and approved. And so we're taking a range of products, including, of course, the usual beta agonists for those athletes who will be able to take them. And I might tell you that we're adopting, as I know many other countries are, because I handle all the applications from around the world, but we're adopting a screening program for athletes in high-risk sports. But in addition, we will be using the leukotriene antagonists and those other drugs like cromolyn or chromoglycate and nitochromol, which are also very good for preventing release of mediators, which are going to cause bronchoconstriction should there be any inferior air quality encountered.
Dr. Fitch, where can our listeners go to get more information if they want to learn more about asthma in Olympic athletes?
Well, the IOC website, if you just Google and look out for the IOC Medical Commission, there is the criteria by which you're allowed to take beta agonists at the Olympic Games, and there is also on it a consensus statement which followed a conference which the IOC conducted in January this year, which looks at a number of issues that we've sort of discussed, including the diagnosis of asthma in elite athletes, the fact that we believe some of them developing asthma almost as you might say an occupational hazard, how best to treat them, the problems of environmental issues such as we mentioned, like cold air, chloramines and air quality. And one interesting thing that we might touch on before we finish, Mary, if we've got time, the success of athletes at recent Olympic Games. And that I find something which I prepared for this particular conference is quite fascinating.
Okay, well, unfortunately we have to close there. Thank you, Dr. Fitch, for being our guest. We've been discussing what Australian sports doctors know about asthma and the Olympic athlete. I'm Dr. Mary Leuchars, and you've been listening to a special segment, Focus on Sports Medicine on ReachMD XM157, the channel for medical professionals. To listen to our on-demand library, visit us at reachmd.com. Register with promo code RADIO and receive 6 months free streaming for your home or office. If you have comments or suggestions, call us at 888 MD XM157. Thank you for listening.